pediatric neurology, that is higher mental function testing. Now, this is often confused with only a very simple sentence of orientation in time, place, and person. But in pediatrics, we should remember that this is not applicable to all the ages. We have a huge range from newborn to adolescent. There is a definite age group when the child is very small, is not very mature in cortical functions, and whereas on the other side of the spectrum we have an adolescent who is very mature from cortical maturation point of view, and we can apply all the traditional sets of higher mental function testing in that child. So normally the expectation of the medical student is that the patient would be highly compliant, fully attentive, and responding to direct questioning, and we can formally apply the standard cognitive tests like MMSE or MOCA, mini mental state examination, or Montreal uh, scale of cognitive function. So in reality, in small children we have very smaller age groups, so we can modify our approach. We should modify our approach, and we should be trying to assess the integrity of the cortical functions and higher mental functions of the children through a playful method. And observation is the only weapon in our hand, and we should always remember that the standard milestones of the particular ages, they should be also taken into account while interpretation of our observations. So on one side we have a small child where it is totally our implicit observation and examination of primitive reflexes, versus the other side a bigger child who is having a mature or human cortex and is subjected to explicit probing and localizing of the deficits in the various parts of the nervous system. So one rule does not apply to all. So here in this presentation we are going to discuss what are the higher mental functions, how do we apply to the different age groups, and how do we record them in our clinical record book and case record in our exam. So first of all, in our exam, whenever we are given a case, we should record the corrected age, exact chronological age, and we should try to correct the factor of prematurity up to 2 years of age to prevent false diagnosis of any delay. Then we should try to document the behavioral state of the child, particularly in the small child, the level of alertness, whether the child is irritable, lethargic, or hyperactive. And we should try to give an account of observation with the caregiver, whether the child is maintaining good eye contact, is reciprocating to the vocal commands, or the child is totally avoidant or indifferent. Now, because of the difficulty of encountering different ages, traditionally the higher mental function testing is divided into three categories. Category A is infancy, that is 0 to 2 years, where we test mostly the sensory motor and the social behavior, like for example visual tracking, auditory responses, social milestones with up to 2 years like social smile, and then at 9 months waving bye bye, and henceforth. The child, we should remember, at this age is very less expressive in language. The vocabulary continues to increase 2 years beyond, and that is why we have a special category of toddler and preschool child from 2 to 5 years as category B, where language development is often tested as a part of higher mental function in addition to our other tests of orientation and communication. So language and construction of the language is having two components, receptive language and expressive language, and this is taken as a proxy for the cortical development, and fine motor adaptive skills. Higher category is category C, where we have school age children and adolescents 6 years plus, where the higher order mental functions like cognition, attention, memory, calculations, abstract reasoning, these are tested in this age group. So we can see that from smaller age group the cortex continues to develop, and cortical functions take little longer time to develop, and that is why we need the at least 6 years age when we start applying the cognitive functions. Now we should remember that still at this age we should not apply the adult sets of testing. In category A, infancy up to 2 years, we can test the social responses at various ages as shown in this image, and basically it is the higher mental functioning exam in this age group is restricted to assessment of basic sensory motor integration and early social awareness. We should remember that beyond this not much is possible by observation, and we should try to document the behavior of the child, the patient's interaction ability, responding to commands, and ability to play. When the child gets a little older, from 2 to 5 years, we start testing for the language function. We are having a receptive language and expressive language. Receptive language means we command the child to point to 4 body parts or to follow a 2-step command, for example, picking a ball and giving to someone. This is receptive language, that is, the patient is receiving the commands. Expressive language means the patient is speaking the words. So, how many words the child is spontaneously speaking, how many words the child is speaking in sentence formation, how far the child is accurately naming his own gender and age. So this is the scheme of examination in this age group. The second part which can be applied in this age group is the visual motor construction. The ability of the child to draw simple figures, like for example copying a vertical line at 2 years, copying a circle at 3 years, a cross and drawing a person with 3 parts at 4 years, drawing a person with 6 parts and copying a square at 5 years. So these are the skills, visual motor skills, which are the indicator of parietal lobe integration and the motor cortex, which require some planning and which are representative of an evolving brain development at this age. So we can see the complexity of the figures. From the left side we have the 2 years a single vertical line, and at 5 years we have a complex figure of a person having 6 parts. So this is how we go about in this age group for the testing of higher mental functions. Category C, we have all those 8 criteria, like for example orientation, attention span, memory, cognitive functions like calculation and abstract reasoning, executive functions like what is the working memory, calculations of mathematics, language, that is comprehension of complex sentence, storytelling, visuospatial skills like mental rotation or constructional tasks, map reading, and social cognition like the feeling part of the human interaction. That aspect is, these are all the aspects of higher mental function which are tested. So we should remember that the higher mental function testing is in various stages involving the various skills which are possible to being tested. For example, we can test only the appearance, behavior, and consciousness in infancy, or let us say 2 years. 2 to 5 years, we can also, in addition to appearance, behavior, and consciousness, we can start our testing of orientation, language, and communication ability. And further on, at still a higher age group, when the patient cooperation is more and more and the cortical development is more and more, we can test memory, attention, calculations, abstract reasoning, and cognitive functions. So these are the stages which we should, this figure tells us that we should remember what is possible at which age. So in a small child, we should not commit the mistake of testing the memory or commenting upon attention span or applying those tests of attention to the small child. And we should not at all expect doing a calculation task for a small child. So stage 1 is the observational exam, where we test the appearance, behavior, and the level of consciousness without even touching the patient. So this is the maturation of the behavior, and on the upper side we have the normal milestones, and on the lower side we have the clinical red flags. So these are the things to be kept in mind if the small child is not interacting or exploring the environment, if a toddler is having hyperactivity or impulsivity, or if an older child is having social withdrawal or not having any feelings. These are called the red flags of the behavior. Regarding consciousness, in the older child we can apply the AVPU scale and modified Glasgow-Coma scale. For the verbal response, we have tests for orientation. We can test whether the person is having a confused speech, inappropriate words, or the patient is having normal language function. The child is communicating to us properly with meaningful sentences. And the motor response, that is, the patient is obeying the commands and localizing the pains and telling about what the child feels. In a small child, we can only test whether the child is alert, irritable, consolable, patient is lethargic or comatose. What is the extent of verbal or vocal response of the child, whether the child is having any sound formation, cooing, or other activities, and what are the motor responses. In stage 2, we have some interaction possible now, and we can, through our commands or questioning, we can test about orientation of the child, language function of the child, expressive and receptive, and communication style of the child. So orientation of a small child is very much possible only by implicit observation. How the child visually tracks to a moving object, is the child turning the head to the mother's voice. And in an older child, it is the explicit observation, where we can ask the child who they are, where they are, and what time of the day it is. So the standard statement of orientation, time, place, and person is just a small part of higher mental function testing. And in the small child, we cannot test, and we should not commit the mistake of saying that the child is oriented to time, place, and person whenever we are encountering a small child. Similarly, age-appropriate language functions have to be tested. In a non-verbal child, we can only see how the child expresses himself, what are the gestures of the child, whether the child is pointing to some object. In an older child, we can test the language by giving some commands, or by asking the questions to the child. So age adopted, we should remember that we should have age appropriate approach to testing of language, and this figure just tells us that what should be the expectation of a physician or a student in exam, how to test the language in a particular age group. Still higher, the cognitive exam, that is the higher human mental functions like memory function, attention span, doing some calculations, abstract reasoning. They are the higher order functions which should be always performed whenever the child is 5 years plus. But that does not mean that we cannot do it in a small child. In a small child, we can just observe how the child is attentive to a particular task. Like we can test whether the 3-year-old or 4-year-old child is busy building a tower or a home, or whether he is easily distractible, or he is totally ignorant of the toys. In a school age child, we can test the digital span by doing a sequence number testing or a trail method of testing. We can test the attention span of the patient like that. Memory function is possible only by 3 years plus child, where we can test some short term memory functions only. And for example, we can show the child any object or any fruit and asking the child what he or she saw 5 minutes back. Long term memory testing is possible only in a bigger child, and like 6 years old or more higher age group, where we can ask the question like, what did you have in your breakfast, dinner, or which class, which school you are in. So this is the higher mental function, memory function, which is tested in the various age groups. We should remember that in the infants, it is a very purely implicit memory. For example, recognizing a parent's face or reacting smilingly to a familiar feeding bottle or cup. Formal testing of memory is reserved only for the older cooperative children. And if the child is comatose, obviously, or the child is under sedation, obviously we can say that these functions cannot be tested because of the state of the child. Calculations, age appropriate calculations should be done from 6 years plus child. This is possible, one, by asking the child which school grade the child is, and asking the child doing some mathematical functions or some poem recitation or something, some activity like that. Abstract reasoning function can be done, for example, asking the child what is the similarity between car and a cycle, what is the why does the sun appear only in the day. So that is these are the functions of complex cortical activity which are possible beyond 6 years plus child. And here also we should remember that we should be giving those calculations or abstract reasoning questions which should be age appropriate according to the school grade of the child or the age of the child. So this table is a summary of all the points we should remember in our higher mental function tabulation and across various age groups. You can see that above 4 years we can apply modified Glasgow scale for consciousness, and we can do complex recalls or serial 7 numbers in a 12 years plus child, whereas in a small child we can only ask about the implicit observation when the child is given some object or a bottle. Similarly, we can test orientation, language, attention across all the age groups. So you can pause here and watch this table again and record the various elements of the higher mental function across various age groups. This is a very, very useful table which you should be able to use and apply in your case. So whenever we have a case in front of us and we have some raw exam data, like what are the milestones achieved, what are the abilities of the child according to the age, milestone abilities. Then we should try to define a higher mental function status in an age appropriate manner, and we should always give due importance to the higher mental functions in our neurological history or examination. Students often commit a mistake of omitting the higher mental function status from the case sheet. So that is a big mistake, because that implies that the child student does not have idea of what are the possible testing of the higher mental function across the various age groups. So higher mental function testing is an important part of diagnostic formulation of any neurological case. And while we are presenting or whether we are recording an inpatient case sheet, this should always be a part of our clinical record in history and examination. Higher mental function status should always get a place in our record keeping. So often the mistake that is done is that we ignore the corrected age of the patients in small infants if they have been born preterm. And sometimes during examination we make the patient uncooperative, and in smaller age groups this is very very important that it is the observation which helps us in recording the cortical development of the child. And diagnosing a deficit without having the knowledge of developmental context is a very big mistake. For example, uh, vocabulary of a small child, of a 2-year old child, is very limited. So he may be enjoying a rhyme or a poem or a song, but we should not expect that he should be able to recite that poem or song. So that is the commonest mistake that we have to avoid. So in summary, we should always say that we should always remember that we should have a keen observation part on the child, particularly a small child, observing the spontaneous interaction, play, and the facial expressions. Playful approach is the only approach across all the age groups. Even in a higher age group, 9-year-old, 10-year-old, we should apply a very friendly approach by greeting the child, shaking hands, and making the child friendly with us before we start asking or putting questions. And context is everything. Whether these changes are acute or having a subacute onset or a long-standing onset, this is very important, because acute deterioration of higher mental functions is leading us to acute encephalopathy or like encephalitis. But a regression of the social milestones, regression of the mental abilities like calculations, falling grades in the school, these are indicative of a neurodegenerative disorder or a condition like SSPE in an older child. So we should remember that higher mental functions, number one, is a very very important part of our neurological case, and second, the context of the entire history and examination should be taken together with the higher mental function, which aids us largely in many diagnoses, particularly in the higher age groups. So that was all, and I hope you have taken the gist of the topic. So I thank you once again for your cooperation and watching this video till this end. I'll be coming another video on cerebral palsy